Hi, welcome to Steps to Strides with me, Connor Ratcliffe, and today we're looking at assessment of shin pain, specifically medial tibial stress syndrome. And for today's video, we have a lovely model, ta-da!
Hello.
Amy, who has shin pain, which is good because, I mean, it means it's in vivo, it's real life. So we'll start off and we'll have a little bit of a talk about what medial tibial stress syndrome is to begin with. And kind of the umbrella of shin splints that it comes under. We'll talk through some clinical signs and symptoms, perhaps a little bit of subjective history, and then we'll go through some weight bearing, non-weight bearing assessments. So, what is medial tibial stress syndrome? And you can chime in at any point. I'm not going to silence you for the full, relaxed, conversational, real life assessment experience for viewers at home. So, medial tibial stress syndrome typically occurs in the distal third of tibia, although it can radiate more proximally, and sometimes you'll read about this and it will actually be called proximal shin splints or anterior tibial stress, but typically when we're talking about medial tibial stress syndrome, we're talking about this distal third. And there's a little bit of variation around within the literature as to actually what causes it and what's going on, but broadly most of the evidence base would agree that it's a combination of intrinsic and extrinsic tibial bending and bowing moments that cause micro cracks within the tibia and a disruption to the bone stress continuum. So it is in essence classed as a bone stress injury. And colloquially, people will call this shin splints, essentially. But there's lots of things in and around this region that could cause the pain. So medial tibial stress syndrome gives us a little bit more specificity as to what the actual pathology is and what the real cause of the pain is. So that's a wordy mouthful, which students will tell you I'm fond of. So what that means is that the tibia actually starts to bend and move, and long bones are good at dealing with compression. They like direct compression. What they don't like is bending and frontal plane movements, essentially. And that's broadly what's going on with medial tibial stress syndrome. The intrinsic and extrinsic bit of that, again, makes you sound fancy and like you know what you're doing sometimes. But broadly what that means is the extrinsic is the ground reaction force. So this is the force that we put through when we walk, run, jump. And that's typically when you see these sorts of conditions in weight bearing activities. You don't get it in swimmers most of the time. Not that I've seen anyway. The intrinsic is to do with bowstringing from like musculature. So typically we're talking about gastrocnemius and soleus as the offending and responsible parties for this. And because of where they sit, they have a bowstring effect. Now the more tibial verum you've got, so the more structurally bendy your tibia is, the more of a bowstring effect it has in actually creating an intrinsic bending and bowing moment within the tibia, which has also been cited as being responsible for some of that disruption to the bone stress continuum. What is the bone stress continuum? Well, it's a spectrum of pathology, essentially. So it's not too dissimilar from soft tissue, like tendon pathologies, really. If you don't do enough and you don't load bone, then you end up with underloading and it still disrupts the bone stress continuum. You end up with osteopenia, osteoporosis. So the bone isn't as strong as it should be. Now, most of the cases that we see with medial tibial stress syndrome are more the other way. So it's a disruption where we have overload. This is why you see it in runners like Amy. More commonly because they do a bit too much or too much too soon, and the bone can't keep up with that repetitive load. So there's stress. There's not enough adaptation time. You end up perhaps with too much osteoclast, not enough osteoblast activity, and then you end up with a disruption in this bone stress continuum and you get typically the first phase, which is a stress reaction, basically. If you then continue to load it, and don't renormalize that stress continuum, it will move into stress fracture. So medial tibial stress syndrome is a precursor to tibial stress fracture. And eventually, if you kept loading it, it would go through to full fracture. But pain limits us from doing that in the vast majority of cases. So that was a bit of an overview of medial tibial stress syndrome. And the reason that we see it most commonly in this sort of distal third is to do with the actual architecture and structure of the tibia. It's the area of greatest varum, and it's the smallest diaphyseal diameter, which again is a fancy way of me saying that is the bendiest part of the bone and the thinnest part of the bone, which is what makes it more vulnerable to these bending and bowing moments. Now, I've actually seen Amy's symptoms before, so I am somewhat forearmed, but interestingly, she has a little bit of what I would classify as periostitis alongside this. So again, depending on what you're reading and where you're reading it, some authors will sort of conflate the two. But when we're talking about medial tibial stress syndrome, I would argue that it is a true disruption to the bone stress continuum, and it is a bone stress injury. Now, some authors have cited the fact that actually soft tissue attachments pulling in this area cause that breakdown to bone. But I would argue that's maybe not so true. And it is more irritation superficially to the periosteum. So you can have these two coexist, and reasonably commonly they do, but they are distinct things. And just in that vein of what is medial tibial stress syndrome, well, I think it's useful to understand that there's still a little bit of variation and uncertainty within the literature about that. But one of the other sort of mechanisms for this is to do with origins of soft tissue muscles in the leg, causing pull on the tibia and causing irritation that way around. Now, absolutely, I agree that can happen, but it doesn't typically cause the sort of symptoms that you would expect on kind of the anterior medial aspect to shin, because nothing attaches there. So we do have flex digitorum longus that sits medial posterior aspect to tibia, and there's a fascial attachment of soleus that also sits in this region. But beyond that, nothing really sits on the anterior aspect where you typically find pain, and it's a different juncture. It might seem like a kind of minor difference, but it actually sits in a different location. So before anyone starts challenging me on the cause of this, I am aware that, that's why you have to be critical, isn't it? Mm-hmm. Amy is also a podiatry student, just FYI. I'm not just abusing a patient. Good. So, typical sort of clinical signs and symptoms that we might see are usually pain when running or doing heavyweight bearing activities, jumping, walking, the like. Sometimes this is worse up and down hills because it increased force through the sort of tibia, and particularly with gastrosoleus and that intrinsic tibial bending bowing mechanism. It's usually described as a dull achy pain that usually starts off a bit worse, eases off a little bit, can be run through, and then you might get a day or so of reactive achy symptoms after undertaking your run, jump, whatever activity you're doing. But it's always runners are the worst. It's unfair, I mean, probably. So anyway, I used to be a runner, so I feel like I can do this and attack runners. So what it doesn't feel like is some of our common sort of differentials for this, the most common for this being anterior compartment syndrome, and that usually presents as quite a different set of symptoms. It's usually more painful, and you don't run through it. It forces people to stop. It's a full burny, achy feeling. If people are particularly good with their pain thresholds, then they'll just keep running until they can no longer use anterior compartment. The foot will start to slap. It presents quite differently. The other thing that you usually don't get is pain on palpation. Now I'm aware that Amy does have pain on palpation, so I'm not going to attack her too much. But you still getting pain through there?
Yep.
So, easing off?
Yep, no.
You got it all the way through still?
Yeah.
Oh, there you go. So Amy's a slightly atypical presentation. Annoying.
Except to about here.
Where she actually gets it distal third, but she also gets it proximally all the way through tibia. So, good example. Well done.
Sorry.
Well, you reflected the true clinical practice rather than textbook clinical practice. Now, the other thing that she gets is this is kind of anterior tibia all the way through. It's right on the bone, and it's really superficial. You can feel that there's nothing else in that area. You're still getting the pain there as well. Sorry.
It's not as bad as it was.
But easing off more proximally.
Yeah. That is definitely just down there.
So this is usually around the region. Essentially what we'll kind of do in terms of assessment for this is find tibia, because that's nice and easier, and then I'll slide my thumb into soft tissue and almost try and hook it around through that kind of musculotendinous junction, so the origin point for soleus fascial attachment and flex digitorum longus. There are two structures in and around that region. So she's got kind of a nice full set of tibial stress and periostitis symptoms here. How long have you had these symptoms for now?
A few weeks, at least 4 weeks.
Good. And anything that precipitated it?
Just running.
Just running.
Yeah.
Good.
So I just started doing more running.
Good.
Yeah.
Okay. And in terms of symptom severity, is it worse on different terrain?
Yeah, sometimes it can be worse going uphill and downhill.
Yeah. You're typical there then, that's good.
Yes, but pretty much it is literally just as soon as I start running. The pain
Does it
starts.
ease off?
Yeah, and then I can carry on running, and then afterwards it feels bad again.
What's your pattern at the moment for running?
I do 3 weeks. I do Tuesday, Thursday, Saturday. So I didn't have a day
You're quite
off.
sensible then.
Yeah.
That's good. And how long do the symptoms last post-run?
Until the next day, I would say.
Okay, so sort of 24 hours post, and then it eases off again.
Yeah.
But
so then I'll run again.
Running, yeah, that's again good. That is typical. That's good textbook for medial tibial stress. Okay, cool. And the type of pain you would describe this as? Don't be swayed by anything I've said to this point.
No, it is. So here it is like an ache, and then in my shins I sometimes get like stinging almost, but also just like if someone touches them, just hurty pain,
Hurty, achy pain. Good, excellent. So I'm not going to beat her up anymore, but palpation is quite sensitive to this, and that's actually is quite a typical set of subjective clinical signs symptoms that you would expect to see with this. Anything that eases it?
Not running.
Not running. Good.
No, not really, to be honest. I mean, even if I'm not running, if I've been doing a lot of walking, that also makes it worse. But I find if I wear shoes that are a bit squidgier, that's helpful.
Good. And again, that's reasonably consistent with what you would expect to see with this. Because it's a load-induced pathology. So if you've got footwear that are more cushioned, then it will ameliorate some of that extrinsic force. So if it's going into compressing the footwear and that force is being mitigated within shoes, it's not going into the tibia and it's not having to be dealt with by the soft tissue musculature around there to either shock absorb or potentially force of contraction, depending on what structure we're looking at, but with soleus in particular, where Amy's got pain around its fascial insertion point. If you're in flatter, less cushioned shoes, then again, it will put it on more stretch and it'll have to work through a greater range of motion, so it makes sense that it would aggravate it a little bit more. Okay, cool. It's a relatively light subjective history, but I'm somewhat aware, and again, you're more bothered about assessment, I would imagine. The subjective history will vary a little bit, but you'll get variations on that theme. And diagnostically, that gives me a good sense of what's going on basically alongside palpation, and then we can target I'm going to call it objective assessment, but it's always a subjective interpretation to it, to see what else is going on. So a reasonable thing to look at here, given that we now have some sense of what the pathology is and kind of the pathomechanics of it, so what's causing it, what's going on, we can look at things that make sense in that context. So given that we know there's this bowstringing effect with gastrocnemius and soleus, it makes sense to look at talocrural range of motion, given we know that potentially there's some issue with incline, decline as well. If we've got limitation in the talocrural joint, that's going to give me some valuable information. And the vast majority of these are going to be soft tissue equinus and limitations. In some cases, actually, what you'll see is there's a lot of range of motion. It's not limited, and either way, that could be relevant and that could be an issue. I will say, before we give you a complex, none of these things are inherently bad.
Yeah.
They're just things. They're modifiable things that in the context of your pathology, then we can deal with and tweak. They're not things that, oh my God, you're broken. Because you're not. Because she told me she's still running 7.5K, which is the longest she's ran as well. But she's still got pain, so she's obviously not happy.
I want to run more than that.
Exactly, like most patients that you see. So we'll have a look at our talocrural range of motion, and then we'll have a talk about, again, why that could potentially be relevant, because it will give me more specific understanding of what Amy's specific mechanism of injury is, and then that can inform my management. So it means I don't have to be generic. I can individualise the management to her specific set of presenting predisposing factors, maybe. So relax me. So we want to put her into a reasonably congruent position at subtalar, because what we don't want to do is test kind of the subtalar joint range of motion. If you don't control in the frontal plane, you'll get a skewed finding in the sagittal plane, because we won't just be isolating the talocrural joint. So it's not necessarily the end of the world, but it's useful to understand what you are and aren't doing and what you are and aren't finding. So we'll keep her reasonably congruent in frontal plane to just test sagittal plane range at tibiotalar or talocrural joint. And actually, I mean, you're not too bad in range of motion. There's a soft spongy end, so it's not a hard abrupt, it's not an osseous block, which is typically what you'd find, and to be honest, that's what you'd expect to find in someone like Amy, who's doing as much activity and as much running as she is. And from my perspective, it tells me that she's not probably too reactive to things in terms of ingraining kind of a protective mechanism and initiating a stretch reflex. So her capacity probably isn't too bad, which we've been keeping again with kind of the subjective amount of exercise that she's doing. Usually when you find real marked sort of equinus, it typically, yes, it tells me that gastrosoleus are tight and in this position predominantly because we're knee extended, we're looking at gastrocnemius, but it tells me usually that there's a deficit within gastrosoleus capacity, because things only really get tight when there's perceived threat. It's a myotatic or stretch reflex. It's initiated as a response, a protective response to something. So I probably don't need to give Amy too much stretching exercises, and usually I don't give tons of stretching exercises anyway. I'll focus on root cause, which is usually the capacity issue. So in this instance, if anything, Amy's actually got good range of motion, which almost tells me that she probably has a lot of range of motion to control. So I'll take that into account when we test her capacity, alongside the fact that she's running 7.5K, she wants to run further. So she needs to have, you know, decent capacity to meet the amount of activity that she's undertaking. Sometimes you'll find that you get like active resistance to this, and again, it's usually indicative that there's an ingrained protective mechanism. There's some degree, perhaps of kinesiophobia, so fear of movement, essentially, because there's perceived threat. They think that I'm going to cause them damage. Maybe Amy just trusts me more than she should, so she's relaxed. But you will feel resistance sometimes, and that's why it's useful to then compare this passive range of motion to active range of motion. So in those patients who you can feel they're just not relaxing, they're not relaxing, I'll ask, okay, right, well, just actively pull your foot up for me. And you can look then to see if you're getting that 10 degrees past perpendicular, and you can compare that active to passive range of motion. So in this instance, I'm probably not too concerned about a marked limitation in range of motion, but you probably have to deal with a little bit more range of motion that you need to control. You mobile or not?
No.
You're not?
I can touch my toes, but
you can touch your
I had
toes?
to train
Good.
myself to do that. So.
Okay, that's fine. So the other thing that you might look at, or when I find that actually there's no marked limitation here, would be their generalised hypermobility or their localised hypermobility. For the same reason, actually, if you've got too much range of motion, then your capacity within those active controlling structures has to be greater. And again, we've potentially got a predisposition for those big, powerful plantar flexors, gastrocnemius soleus, to work a little bit harder to decelerate relative dorsiflexion when she's in gait. And if they have to work over time, essentially, because there's not a lot of passive restriction through ligamentous structures, then they're going to contract more, they're going to cause potentially more intrinsic tibial bending and bowing moments. So you can infer a reasonable amount from a relatively simple test. I mean, you're not massively flexible, are you?
Mm-mm.
So there are tests for like actual localised lower limb hypermobility, but they're lengthy and open to all sorts of error. So I tend to do this more on, is a bit of a subjective experiential yardstick, but it's feeling for passive restriction within the foot joints and whether or not there is lots or limited, essentially. I'm sure some people not enjoy. But yeah, the lower limb hypermobility score, it's mad. And have you ever looked at it?
I think Manji put it in one of her lectures.
Yeah, I'm sure it is a validated thing, but at points it's saying about like the difference is 10 degrees, and you're thinking, how am I going to approximate that?
Oh yeah, surely you'd have to be good at...
There's lots of room for like subjective error in it anyway. So you're not high on Baton scale?
No, I can't do any of that.
Good. So Amy's not generally hypermobile.
My arms, I don't think.
You got a little bit of hyperextension elbow.
What's that, so 1, 2?
Yeah, you're probably on 2, aren't you? Because you're not recovered, really.
No.
You can touch your toes though,
So
can you?
3.
So, I mean, you can go away and look at Baton scale, but you'd usually consider people hypermobile when they get to 5 or 6 or above out of 9, again, depending on what you're reading. But not relevant in this case, which is good. So the next things that we're going to look at are some manual muscle testing. Again, we know that this is a load-induced pathology. So from my perspective now, what I'm concerned about is Amy's ability to be able to decelerate rate of loading. So I'll look at some of those key structures that are going to be involved with being able to decelerate rate of loading. So gastroc and soleus are obviously 2 of those structures, and we've discussed how that interrelates with talocrural joint range of motion, and they're going to, as concentric plantar flexors, eccentrically decelerate dorsiflexion through gait, and that's quite a useful kind of concept to understand, especially in this context, because of their bowstring effect and because of the fascial attachment of soleus. So if they fatigue out and they can't decelerate that rate of loading very well, you'll end up with rapid rate of loading and both intrinsic tibial bending as well as a big pull on soleus's fascial attachment and that periostitis. Actually, testing this in chair isn't very useful, to be honest, in my opinion. If you were doing this with sort of dynamometry and getting an objective measurement, yeah, fair enough. But most of the time because they're big, powerful structures, you're always going to find that people can overpower. So if you just push down against me, but you'll very rarely get marked weakness, non-weight bearing, but it's a simple thing to do still. And you can assess still like non-weight bearing provocation of active plantar flexion. In my experience, I mean, that didn't cause you any pain?
No.
It very rarely does, especially again in this context where Amy can run for 7.5K. So doing this against my resistance, non-weight bearing, it's unlikely to provoke, but you could do it, and that's kind of the rationale why. And essentially, you're just putting them passively into a dorsiflex position and getting them to push down against you to see if there's marked asymmetry. In your case, you've got bilateral symptoms anyway, so you might not expect asymmetry, but if there was, again, or pain on one side, not the other, presumably no pain on that side either.
No.
It might tell you something, again, it gives you some yardstick as to how you're going to reload this moving forward. But at least you're consistent, so that kind of makes sense with what else is going on. Other structures that I'd be interested in are tibialis anterior, because that's going to be sort of the main deceleration structure as we come into initial contact. Obviously this gets compounded in runners because you have a float phase, so there's acceleration into ground contact, and then tibialis anterior has to work really hard in conjunction with extensor digitorum longus, extensor hallucis longus, to decelerate that rapid plantar flexion into ground contact. So to test this, we're going to put you in the opposite position, basically, to its concentric function, which is big words again, isn't it? So it dorsiflexes and it inverts. So we want to plantar flex and evert the foot, essentially. So you're going to pull the foot down and out, and you're going to ask your patient to pull up and in, right? And it's useful to move them through the arc of range of motion that you want to begin with, because especially when you're going multiplanar, so we're going to work through sagittal and frontal plane with dorsiflexion inversion, it can be a little bit trickier of a movement. So I'll typically move them through the range that I want, and then I'm going to get you to pull up against me. So pull up and in. Good. Any pain?
No.
And she's nice and strong as well, which you'd expect again, given how much she's running. And Tibant's a nice easy one to test because you can see nice big tendon when you do it. So we're going to put foot down and out, plantar flex evert, and you're going to dorsiflex invert, so pull up and in. Good. And again, there's no marked difference from one side to the other, so you can pull up, overpower me reasonably well, and we get nice engagement at Tibant. And actually, you're quite good. Well done.
When I was a kid, I used to walk on my heels, like just for fun.
Just for fun?
I know I've learned that can strengthen your Tibant.
Yeah, maybe it's done you some favours. Your childhood idiosyncrasy. Well done. So things that I would look for when I'm doing this is engagement of tibialis anterior tendon to make sure I'm getting the target structure that I actually want to test. Just pull your foot up again for me without thinking. Ugh.
Oh.
Yeah. So that's do it. Good. So what you'll usually find in most people, say Amy is actually not too bad, is that you'll get extensor substitution. So when you do this unbiased without thinking, and everyone does this, it's not abnormal, you won't pull up and in, you'll just pull up, because it makes more sense to do that, basically. We obviously want to bias our testing position to make sure we're isolating our target structure as much as possible. Now, obviously, as previously mentioned, tibialis anterior isn't the only dorsiflexor here, and you'll never entirely isolate between extensor digitorum, extensor hallucis and tibialis anterior, but we can work to try and do that. So when you do this unbiased, just pulling the foot up, you'll get them all engaged, and again, you're nice and superficially tendony. So you can see nice tendon exposure on this, and if I move you back into more of an inverted position, the extensor digitorum longus tendon goes back into foot, basically. The easier thing to look for is digital dorsiflexion. Now again, this doesn't necessarily have to be a massive problem or an issue. In the context of medial tibial stress syndrome, having all of those dorsiflexion structures working synergistically, working together is a good thing, because our overarching goal here and aim, merge the two words there to make game, is that we want to decelerate plantar flexion to help with rapidity of loading through tibia. So we don't need to worry too much about that, but if it was really obvious that there was lots and lots of extensor substitution, and Amy really struggled with that dorsiflexion inversion position because she really wants to use extensor digitorum longus, which dorsiflexes and everts, well then when it comes to our management, actually that might be quite a useful thing to know, because if she's primarily biasing that dorsiflexion to extensor digitorum longus, then what we might have is a bit of synergistic dominance. So it's doing all the work basically, and we're not using all of those structures. You're just using extensor digitorum longus, and then that's going to fatigue out quite quickly. So we might need to very specifically bias that movement to make sure we're getting them all doing their fair share of work. So you're not actually too bad in this instance. Like most people, if you do it unbiased, yeah, you'll go into a normal position and you get a little bit of extensor substitution, but you switch those off quite easily. She's making that look easy, but you don't see that all that often, and lots of the time people will struggle with movement. So in that case, what we might do is put them into a plantar flexed and inverted position and just get them to focus on the sagittal plane movement. So now you're just going to pull up against me. And that way, it's usually neuromuscularly a little bit easier. And yeah, you're not too bad again with extensors engaging. We could also obviously be concerned a little bit about extensor hallucis longus, but it also dorsiflexes invert. So unless you've got marked digital helical dorsiflexion and no tibialis anterior tendon popping out of anterior ankle, I'm usually not so worried about that pattern, to be honest. It's the lesser digital dorsiflexors that's usually the troublemaker, and where you get extensor substitution patterns coming in. So anyway, probably don't need to worry too much about the specificity of our dorsiflexion exercises for you, which is good. The other one that I would then be kind of considering is looking at tibialis posterior. So tibialis posterior is going to decelerate rate of pronation. So as we come from initial contact through into mid stance, essentially. So if it doesn't work very well, then we're going to end up with a big rapid slap across into frontal plane. And again, if it doesn't nicely decelerate rate of loading or fatigues out, that load has to go somewhere, and potentially that's going to go through tibia and cause some of Amy's symptoms. Obviously, it also acts as a plantar flexor. So whilst gastroc and soleus are our main primary plantar flexors, that is also one of tibialis posterior's jobs. So if it doesn't do its sagittal plane plantar flexion function very well, again, you're removing a reasonably big, powerful plantar flexor, and you're making gastrocnemius and soleus do all of that work. Other plantar flexors are available with peroneus longus, peroneus brevis, flexor digitorum longus, flexor hallucis longus, but they are typically smaller, obviously in their volume and capacity. Again, before anyone starts having a go at me for anatomy. I do know it. So if we want to test this again, we understand what it does. It plantar flexes inverts, so we're going to dorsiflex evert, put the foot up and out, and we're going to get our patient to push down and in. All right? Good. Push down and in against me. Good. And again, she's pretty good at that. Good. And there's no pain.
No.
No marked weakness, which, to be honest, I would expect that again, given how much activity she's doing. So same with the other one, you're going to push up and out, you're going to come down and in. Push down and in against me. Good. And again, no pain.
Nope.
No marked asymmetry or anything that's upsetting me there. Similarly to testing tibialis anterior, and in this instance, if we just wanted to isolate frontal plane, because we're probably a bit more worried, in fairness, most of the time about its frontal plane deceleration of pronation, then we want to bias away from tibialis anterior this time. So we're going to pull foot down and then you're going to push foot in. Good. And then in this position, if I wanted tib ant as well, I'd just pull foot up and then push foot in. And again, you can see the difference in tendon popping out of foot, basically. So you've got a few different ways to manual muscle test and see if any of these provoke symptoms. These can also be quite useful as potentially there's sort of differential diagnosis from muscle belly pathologies of these structures. So it helps, you know, consolidate our work and diagnosis based on location of pain, symptoms and palpation that we've sort of found earlier. To be honest, from a non-weight bearing perspective of foot and ankle, I probably wouldn't be too concerned about much else. I might look at first met foul range of motion still, just because it gives me a little bit of a sense of mechanics and potential compensations that might occur. And you've got a little bit of thickening around joint, but otherwise you can achieve 65 degrees range of motion. So there's no structural deficit here. Most people at some point in life will end up with functional hallux limitus. You just have to fatigue enough or be over enough uneven terrain to get jam in a joint, essentially. Now, that could still be relevant as it kind of gives us a bit of a sense of what's going on with some of the soft tissue structures that help control that range of motion. Again, with our our big inverters like tibialis anterior, tibialis posterior, and also peroneus longus and its role in medial longitudinal arch stability. So all of those things reasonably could impact. And if they're having to work hard to deal with old mechanics at first met foul, or if it lets me know that maybe there's going to be some compensatory strategies going on, it could be related, but it's probably not my first go-to for medial tibial stress. We could look at perineal function. Again, in terms of shock absorbency, I'm actually not so worried about those most of the time. So less relevant most of the time given the pathomechanics of medial tibial stress. Where it might be relevant is to do with stability generally. If you've got marked deficit in perineals acting as big lateral stabilizers, you're potentially going to end up with more instability. And if you've got more instability, other structures that have to work within that role of stabilizing foot will work more. So they become prematurely fatigued. Gastroc-soleus are some of those, tib ant, tib post are some of those, albeit not specifically lateral stabilizers, they will act as stabilizers. So if the perineals are fatiguing out prematurely, everything else has to pick up the slack from a stability perspective. And potentially, again, that's increased force of contraction or increased fatigue, which then means we can't decelerate rate of loading as well, and we end up potentially with a mechanism for overload again. Most of the time I'd be more inclined to test this weight bearing, but as we're here. If we want longus brevis, then typically I would either plant a flex foot and then get you to push out against me. Good. And yeah, as expected, you can see Amy's tendons, so you know you're getting contraction, but otherwise you can feel into muscle belly. Again, you've got no marked weakness, so I wouldn't have thought you would. Or pain. If we wanted to test them through full arc, they plant flex evert. So we have to dorsiflex invert, and then what you're going to do is you're going to push down and out against me. All right, so we're going to get it to plantar flex evert, down and out. It's a weirder movement.
That's weird.
Yeah. So this is sometimes easier to just test in sort of single plane, plantar flex them, get him to evert. If we wanted tertius, well, we know that runs anterior to ankle, so it dorsiflex everts. We're going to just bias the sagittal plane position, put her into dorsiflexion. Now you're going to turn out against me, just push out against me. And to be honest, most of the time what you actually get is extensor digitorum longus that engages. So that's where you have a bit more substitution, but that's a biased position for extensor digitorum longus to work anyway. So that's normal, but you see the digital dorsiflexion, which lets me know what's working basically in my test. So we'll look at sort of sideline abductor strength. This is my typical go-to, and it's just because you get good control. You'll see lots of proximal compensation with people for this. So you can do things like single limb knee bend, you can do step downs for this and look at dynamic knee valgus, and that gives us some sense about proximal strength. So in external rotators, abductors of hip is what we're kind of concerned about in this instance. But it can still be driven by foot, so this isolates movement a little bit more, and in this position, again, it enables me to just have a bit more control and feel where contraction's coming from. So what people will typically like to do is roll pelvis back, because it gives more mechanical advantage to some of these hip flexors to work as abductors, so you can stabilize and stack pelvis in this position. What you can also do is feel for contraction within glute med, and within TFL with fingers, so it's a useful position. And I'll talk about relevance of this perhaps when Amy's weight bearing to illustrate this a little bit more. But basically, if our abductors aren't working particularly well, then there's a predisposition to crossover gait or runner's varus or a scissor gait. They're all the same thing. And basically that creates a varus limb, so it makes the whole limb in a varus position, irrespective of whether or not we've got tibial verum, so a structural frontal plane bend within tibia. The whole limb goes into a varus position, and then the oblique forces, they don't stack through the longitudinal axis of tibia, they'll pass through it obliquely, and it predisposes that extrinsic, so outside force, to creating tibial bending bowing moments. So this is quite a useful thing to look at alongside sort of dynamic movement. So watch people run, especially when it's runners who are presenting with these symptoms, because you'll see that narrow base of gait. Sometimes this is fatigue induced, so you might not see it straight away, but that's again where kind of combining multiple tests and multiple assessment is useful. So, wordy again, aren't I?
I just want to say, when I do run, when I've been getting tired, I've noticed I do like kick my ankles. I like really
good
cross over.
So that then you'll see it sometimes where people end up with like mud inside the medial
I do.
leg, which is indicative that they've got narrow swing through. So there's probably a bit of adductor dominance or premature abductor fatigue. And again, runner's varus isn't a bad thing. Like most people will run on a narrower base of gait, it's metabolically efficient to do so. But in the context of this presentation, it could be a causative factor and something that we can intervene with a little bit. And typically I would intervene with it building strength first before I did gait retraining stuff. So my preference is I'll test muscle strength first, then I'll look at movement pattern and you running on treadmill. So cool, we're going to stabilise pelvis, we're going to feel for contraction, you're going to keep bottom leg bent, you're going to straighten that leg for me, good. Now the other thing that people like to do for this is they like to be in hip flexion, same reason it means you can use hip flexors. What we want is to come into some hip extension, and you'll usually know how far you can go because you'll feel more resistance and you'll start to see a lordotic position. So you'll start to see lower back go into lordosis essentially. So you're just going to bring them into a bit of comfortable-ish.
Yeah.
Good. Hip extension. We're going to feel for engagement, and then we're going to bring up to about 45 degrees abduction or so. And then what I'm going to do is I'm going to let your leg go. You're going to hold it there. All right.
I'm going to try.
So hold in that position for me. Not too bad, Amy. It's good. So relax me again. I'll hold. Now we're going to take her into a little bit more hip extension and come up into about 65 degrees or so ish of abduction. And now we're going to ask her to hold in that position. All right. Hold in that position. You're not as bad as you thought you were.
I mean, I can really feel it though.
Yeah, it's fine. So typically the fail for this is people pull forward, drop down, and Amy's actually able to hold this reasonably well. The last test for this is then you'll resist me basically. So for this, you can actually test both planes. Now I'm more concerned about frontal plane again and a resistance to adduction, so me pushing down. But because they're also external rotators, I can push down and in. and you have to try and resist both, basically. So you can do the transverse plane external rotation if you want, but I'm less concerned about it, and it makes it more complex. So we're going to start here. I'm going to push down, you're going to resist me. All right. Good.
Oh.
So that's where she's probably got a little bit more weakness, but for most people, that's actually quite good. Most people will fail on first test, so about 45 degrees abduction, they'll drop, pull forward, and there's no need to then do any further testing. It lets you know that there's a relative weakness. But Amy's actually quite good, relatively, inside line, but given that she does get a little bit of kick on the inside of leg, and she's running quite a lot and still can't resist me particularly well, the likelihood is there still probably is a little bit of weakness relative in that area. So that gives us another target structure that we could look at, but proximal works harder than distal. So usually I'll go there if I have to. Good. So in terms of weight bearing assessment and things that we might look at for medial tibial stress syndrome, foot posture is an easy go-to. An exaggerated foot posture, one way or the other, is relevant in this instance. And I mean, you're not too bad really, are you? Amy is fairly neutral. What she has got in weight bearing, you can hopefully see, she's got a nice tibial verum. So if you just turn around, face away from us. Good. It'll always force foot to rapidly pronate into ground contact. Roll out for me. Come in a little bit. Yeah, good. So, because of her nice tibial verum, relax. It'll always force her to pronate across to achieve ground contact. And obviously, when she runs and starts to fatigue, that'll happen quite rapidly. So, we could end up with a big rate of loading coming through tibia. Other than that, say she's not massively pronated, or she's not massively cavoid in this instance, both of which can be relevant because it can influence ability to shock attenuate essentially. So cavoid feet typically, characteristically, are poor shock attenuators, and if the foot and ankle architecture isn't working particularly well to dissipate or ameliorate external force through pronation mechanism of subtalar joint, then that has to go somewhere. Now that's either going to get absorbed by gastroc and soleus and they're going to act as dampeners, and again potentially that will sort of feed into this intrinsic tibial bending bowstring issue, or it's just going to directly go through osseous structures, and rather than it being nicely mitigated through effective pronation, it's going to go into tibia and increase the bone stress loading moment. Essentially, it'll increase force or rate of force loading. When we've got markedly pronated foot type, essentially it just increases the amount of work that our inverters have to do to effectively decelerate rate of loading, and they have a shorter lever arm because of a typically medially deviated subtalar joint axis. So it predisposes them to fatigue out quicker. And again, that might be something that we need to take into consideration when we think about the capacity within those structures. But from a foot posture perspective, apart from being a little bit pronated relative to leg because of tibial verum, she's fairly neutral. So not too concerned, really, which is always good. That's what you want your clinician to say, but they're not too concerned. Just stand on one foot for me, either or. So we'll look at proprioception, and again, similar to our sort of non-weight bearing discussion, what we want to see is how stable she is in a single imposition, because this is stable surface without complex movement and without fatigue. So when she's 5k into her run, over uneven terrain, potentially, we're going to be in a different position and everything has to work a little bit harder. No, actually, you're not too bad, which is good.
This is my good side.
That's your good side, is it? To the other side then. And I mean, you'd expect Amy to be good. She flexor stabilizes a little bit. You can see apices of digits are just blanching, so she's just driving into ground, but not too concerned about that. I'm concerned about stability as opposed to where that's coming from. And yeah, there's maybe a slight deficit, but she's not awful. The relevance, again, in terms of why we care about this is that we want there to not be lots and lots of adjustment, because if you've got more adjustment, you've got more movement, i.e. proprioception is a little bit diminished or relatively diminished, you've got more displacement basically. And if you've got more displacement, you have to do more work. Work done is force times displacement. So if there's more movement, even if it's, it appears to be minimal, when you do that lots and lots and lots and lots, everything has to work harder. Premature fatigue, and that can either inform the ability for these structures to decelerate rate of loading, or how much they have to contract and then pull at some of these areas that are causing the pain from that periostitis perspective. So that's something we could probably do a little bit of work on. The other things that I would look for are, this is where it's much easier and better in my opinion to test gastroc soleus capacity, because one, they act as shock absorbers, two, they decelerate relative dorsiflexion through gait, so rate of load in that way, and obviously if that happens really rapidly, then we'll end up with a big intrinsic bowstring mechanism that can upset tibia. And just because Amy's got a little bit of periostitis around where soleus's fascial attachment is as well, it seems like a relevant thing to test. So, as I say, non-weight bearing, not so relevant. Weight bearing, especially in a runner, more relevant. So you can hang on for this, it's not a balance exercise. I'm not going to make you do tons and tons because it's a bit cruel, isn't it? But I would do this to fatigue, essentially. So I'm not even going to be too bothered about you doing double limb here, because of how much running you're doing, the fact that you've not got marked pain on non-weight bearing, I would expect you to be able to do single limb tiptoe raise, basically. And you can.
Yeah.
Wonderful. Do you get pain?
No.
Good, which again is usually typical in these sorts of cases, but we'd look, if you turn around and just face away from me, hold on again, we'd look to see a capacity to fatigue, and I'd expect someone like Amy to be able to do 30 decent tiptoe raises, so through full range of motion and nice and slow on the way down, so a count of 2 or 3 on the way down. Given the amount of activity that she's doing, any less than that will probably be a bit of a mismatch in her existing capacity versus the amount of activity that she's doing. Just do it again for me. The other thing that I'd look for is the calcaneal inversion when she's doing this. So because we're, previous conversation, concerned about tib post function, we want to make sure that we're getting that frontal plane inversion, come down slow, and that it's able to decelerate that frontal plane range of motion as well. So we could potentially target both of those structures if we started to find that there was just, an absolute deficit. She could only perform 15, for example, or towards the end, she could get to end range plantar flexion, but the calcaneal inversion started to drop off. Again, it gives me the idea where the capacity deficit is and what to target later on. So that biases towards gastrocnemius because we're in a straight leg position. So what we want to do is also test soleus. So to do that, we can make gastrocnemius actively insufficient. Yes, well done. Amy knows what that means, which is helpful. Not all patients will. What that means is we can flex the knee. So if we flex the knee and we slacken a bi or a triarticular muscle across multiple joints, it makes it harder for it to engage. So when we flex the knee, it slackens gastrocnemius, and it means that we bias the load to soleus. And again, then we can test bent knee tiptoe raise to see what our capacity is like within soleus. Now this usually is a much more awkward movement. Don't mind the crack. And people will struggle with this a little bit. Can you do that side on? Hold on there for me. Good, come up. Naomi's actually quite good at that because she maintains knee flexion. So she's actually doing this how you'd want her to do it again. So she stays in that position, which is good. What you'll see some people do is they'll come up and they'll extend knee as they do it. So they kind of do that, and it becomes a bit of a cheat. That is what you want, good. And now sometimes this will feel a lot more challenging around quads for people as well. but keep going for me. Feel all right?
Yeah.
You don't often get a provocation with this. It doesn't usually cause pain, and you would usually find less reps in bent knee. But if Amy could do 45 straight leg and 7 bent knee, it'd let me know that there is a bit of a mismatch and a discrepancy between gastrocnemius and soleus. And so even though gastrocnemius is testing reasonably strong, it's broadly trying to do the job of 2 muscles, because soleus hasn't got any gas in the tank. It can only do 7, and over 7.5K, it means gastrocnemius is going to be synergistically dominant. It's going to do all the work, then it's going to fatigue out, and then soleus has got nothing to give, unfortunately. So then she's not going to be able to decelerate relative dorsiflexion. They're not going to be able to shock absorb very well. She'll end up with increased rate of loading, potentially some of the irritation that she's experiencing. What is your absolute value, do you know?
12.
12.
And that is recently up from 10.
Good.
It's like a struggle to get there.
Good. So she did have a bit of a deficit, yeah. And again, I'm not going to force you to do this on our horrible hard floor. And it's probably going to be quite a long video for me to edit already. So yeah. I won't get you to do it for fatigue. But they're useful weight bearing exercises to do in the context of medial tibial stress syndrome. The other thing that would be quite a useful thing to do are hopping exercises. So single limb hop is a good test and a good predictor for return to run. Now I'm hoping you can do a single limb hop without pain.
I'll try.
Okay, good. Do a single limb hop for me. Good. Any pain?
No. Good chance.
Good. Good.
No.
No massive pain at least.
No.
Good. No, I mean, that should be consistent with the fact that she's doing quite a lot of running as it is. So I wouldn't be too upset. But if you ran yesterday and you told me it hurt, fine, it's reactive, I get it. But usually if they can't hop without pain, they probably shouldn't be running. Now, the other thing that you can look for when, I mean, you did that quite well because you've been practicing this. But the other thing that you can look for with hopping exercise is patient's ability to attenuate force. So Amy was actually quite quiet when she did that, but some people will be a lot louder and you'll see a lot more vibration in lower leg where the musculature is absorbing that force and the lower limb isn't doing a particularly good job at attenuating force through hip, through knee, through ankle joint, so tibio-talar, subtalar joint mechanics. So she's been practicing her creepy hops, as she calls them, which are soft hops, and essentially it's a cue that we'll give to management. So it means that you can engage multiple structures to decelerate rate of loading throughout a whole lower limb. But when you don't practice this and you do it uncued, you'll see some people are a lot thuddier, a lot heavier, a lot more lower limb vibration, and we'll try and cue that out so they're quieter, essentially.
I did sound like that at first. And
Good.
I did have to cue myself out of doing
Well, that's
that,
good. That means management's working.
Yeah.
It's a little preview into the management side of this. But in terms of weight bearing, sort of static, semi-dynamic things, these are good things to do. We can have a look at single limb knee bend as well as an alternative. Okay. Are you good at single limb knee bend?
I don't think so.
Okay, cool.
Holding on? Or
No, not holding on, because this isn't, yeah, so you do get dynamic knee valgus as well.
Yeah, let's try this.
Yeah, shift yourself that way. So, see the frontal plane. Ooh, yeah. Come on. Ooh, yeah, well done. Don't make those noises at patients when they do this. But again, that it is actually, it's a more challenging movement because it's weight bearing and you've got multiple joint involvement to control as opposed to side lying. But yeah, there probably is a little bit of poor control in frontal plane there that we could also look at. Again, when you're unfatigued, stable ground without as complex a movement as running, that can get compounded and make sense of why we're getting a bit of crossover gait in that varus limb position and oblique force rather than stacking under hip. Cool, so based off of some of our non-weight bearing and weight bearing assessments, I think it's a good idea to have a look at what's going on functionally for Amy. Now, in just walking gait on a treadmill, this obviously isn't necessarily reflective of what she does outside on different terrain when she's fatigued and potentially when she's in pain as well. All of that will sort of skew how she moves a little bit, but it gives us some sense of movement. But take it in the round of our other assessment findings. Don't just rely on gait analysis. Now, I mean, just to walk on treadmill in her running shoes, there's nothing particularly remarkable in a good way. So there's a little bit of lower limb vibration. Otherwise, slight abduction, nothing significant. You're perhaps slightly narrow on base of gait when you're walking. So she's perhaps not stacking entirely under hip. Cool, do you want to build up to a run? Just pick a comfortable pace. Now, one of the other confounding factors here is Amy potentially feels quite self-conscious as I film her and talk about her and stare at her, and obviously this is a risk that can happen in a normal clinical assessment environment as well, which is why it's useful to have all of your assessment to take together. So hopefully that gives us a good kind of overview of what medial tibial stress syndrome is, some of the clinical signs and symptoms, and some of the potential assessments and rationale for these assessments that help consolidate and confirm our working diagnosis, but also the specific mechanisms of injury, so we can then be more specific in what we might want to target moving forward in terms of our management options.